Good day, this is Dr. Ahmed Midhat al-Shafi'i, Lecturer of Otorhinolaryngology, Faculty of Medicine, Helwan University. Our topic today will be sore throat and pharyngitis, and the second section of this presentation will be for tonsil and adenoid disease. The definition of sore throat: it's a discomfort or pain and even scratchiness in the throat, known medically as pharyngitis. It's a symptom of many medical disorders. The causes mostly is viruses, the flu in rhinovirus and influenza. It's about 90% of the infectious causes. Also the COVID-19 have a presenting symptom with sore throat, bacterial with strep and diphtheria, fungal and systemic diseases, which we will discuss later, like leukemia, granulocytosis, and infectious mononucleosis. Ulcers of the oral cavity with different causes like irritants and stress, cancers, could be malignant ulcers, and with immunodeficiency virus syndrome, the AIDS, and the gastroesophageal reflux disease. Also, mouth breathing due to nasal obstruction causes dryness and soreness of the throat. So mouth breathers have commonly presenting with dry and sore throat. Also, sinus disease drains posterior nasal discharge, which continuously drains over the throat and causes a dry and sore throat. Start with pharyngitis. First, acute pharyngitis. It's a very common and it has various etiological factors: viral, bacterial, fungal, others. Viral is the most common, and the acute streptococcal pharyngitis due to the group A beta hemolytic streptococci. It's with the most importance due to its link with the rheumatic fever and glomerulonephritis post-streptococcal infection. Also, it may be secondary to sinonasal disease like acute sinusitis with draining of the pus, irritating the throat, and also extension of the infection, and with a causatic injury, which is something irritant like an acid, and something irritant to the throat, and also the chronic allergy with the dryness and the continuous discharge on the throat causes such maybe a cause for such a disease. The pathogens, viruses are the most common, with the rhino and influenza and parainfluenza. Also the measles and the chickenpox, Coxsackie, herpes simplex, infection mononucleosis, cytomegalovirus, also Epstein-Barr virus. Also the bacterial, we should be considering streptococci, the group A beta hemolytic streptococci, diphtheria, gonococci, and the fungal with also other like parasitic toxoplasmosis. The bacterial is less common than the viral, which is obvious. Mostly the herpes simplex in the viral infection, accompanied with a common cold. It has vesicles, oral and circumoral vesicles. When they rupture, they tend to be very painful. There are multiple vesicles. Also the herpes zoster, which is more painful. Also the chickenpox and the measles have in the prodromal phase. It has the virus throat, mostly with a diffuse congestion all through the pharynx and the oropharynx. Sometimes we can see vesicles and vesicles of herpes. It's more commonly on circumoral, less commonly in the throat. This is the picture of these vesicles. Clinical features. Different grades of severity in pharyngitis presentation. Mild infections, they have discomfort in the throat, sometimes they have low-grade fever, malaise, and bony aches. In these cases, the pharynx is congested, but there is no lymphadenopathy. Moderate to severe infections present with very painful throats and dysphagia, headache, malaise. Severe cases show erythema and oxalate and enlargement of the tonsils and lymphoid follicles in the posterior pharyngeal wall, which shows a granular posterior pharyngeal wall. And also severe cases has severe edema of the soft palate and uvula, and also the cervical lymphadenopathy is the character of the moderate and severe cases of viral pharyngitis. It's not possible on clinical examination to differentiate between viral and bacterial pharyngitis. But viral infections are generally mild and are accompanied with runny nose, hoarseness, and change of voice, while bacterial ones are mostly severe, and it takes a longer time. The symptoms may carry with the patient for a longer time. Gonococcal pharyngitis, it's mild and might be even symptomatic. Gonorrhea is an STD, a sexually transmitted disease, and syphilis, they are different, have a different presentation. It's less common to be diagnosed. Maybe sometimes diagnosed in cases with resistant pharyngitis. For diagnosis, we have different tools. The clinical examination with the proper history taking, and considering to take also culture from the throat by a throat swab and the smear for the viruses. This is rarely indicated, mostly in resistant cases. These swabs can detect 90% of group A beta hemolytic structure cocci. Sometimes you might need a special media like diphtheria. Swabs from suspected case of gonococcal pharyngitis should be cultured immediately, and failure to get any bacterial growth suggests a viral etiology. At the general scheme for the treatment, the use of supportive care as proper rest, proper hydration, humidity in the surrounding environment of the patient, lozenges, anesthetic sprays containing xylocaine, and iodine gargles might help controlling the infection. Antipyretics for fever, and also as analgesics. Decongestants might ease the symptoms, especially in rhinorrhea, but might cause some throat dryness. Antibiotics only for bacterial infection. Those diagrams for cases of acute pharyngitis might be viral or bacterial cause. Chronic pharyngitis is a chronic inflammatory condition for the pharynx and the pharyngeal mucosa. Hypertrophy of the mucosa and the gland in the mucosa and the lymphoid follicles, even the muscular coat of the pharynx. There are two types: chronic catarrhal pharyngitis and chronic hypertrophic cranial. The etiology: persistent infection in the neighborhood. In chronic rhinitis and sinusitis, where there is a posterior nasal discharge continuously discharging over the oropharynx, this causes hypertrophy of the lateral pharyngeal bands. Similarly, chronic tonsillitis and any recurrent dental infection also responsible for chronic pharyngitis. Also, the mouth breathers. This exposes the pharynx to dryness and lack of filtration and humidification, and adjusting the temperature of the air, this making it susceptible for infections. Mouth breathing is due to obstruction in the nose, whether it's polypi, allergy, vasomotor rhinitis, hypertrophied turbinates, and deviated septums, even tumors. Obstruction of the nasopharynx, where is adenoids or tumors, and sometimes dental problems might be a cause of chronic mouth opening. and can be habitual after exclusion of all other causes. Chronic irritants, smoking, chewing tobacco, as is famous in some countries and some cultures, drinking highly spicy food in some countries and some cultures. Also, all of these lead to chronic pharyngitis. Environmental pollution, dusty, smoky, irritants, industrial areas also might be cause of chronic pharyngitis. Sometimes people have habitual faulty voice production, excessive use of voice. Certain professionals, they have some sort of professional neurosis with constant the symptoms: discomfort, pain in the throat as usual, especially in the morning. Also, dryness is another complaint. Foreign body sensation in the throat. The patient say in his own words, "I have a feeling there is something stuck in my throat." Constant desire to swallow and clear his throat. Tiredness of his voice. Patient cannot speak for a long time and has to make undue effort to speak as his throat starts aching and itching. The voice may also lose its quality and may even have some cracked sound. Repeated cough due to irritable throat. Also, opening of the mouth may induce also the signs for chronic catarrhal pharyngitis: congestion of the posterior pharyngeal wall, vessels engorgement, and the pillars for the tonsils might be thickened. There is increased mucus secretion, which may be the chronic hypertrophic granular type, with congestion, thickening of the dilated vessels, and reddish nodules due to hypertrophy of the subepithelial lymphoid tissue. This could be seen due to different causes, but this is diagnostic for granular hypertrophic chronic pharyngitis. The lateral pharyngeal bands might be hypertrophied too, and the uvula might be edematous and elongated in some cases. History taking and examination, cultures and biopsies. Sometimes we start with empiric therapies, and the treatment mostly search for an etiological factor, give the patient advice, and to try eradicate this cause. Treating the cause, what we do first: voice rest and some speech therapy advice from a speech therapist. A professional can give some advice for the patient to avoid this faulty voice production, avoid clearing his throat, and also proper hydration to avoid such habit. Warm saline gargles in the morning to avoid dryness, and some enough hydration. Bacterial infections, the presence of normal flora in the oral cavity with gram-positive aerobic organisms and anaerobic organisms. Streptococcal is the most common, especially in kids, with the famous group A beta hemolytic streptococci. Other streptococci may be involved, but it have been linked with severe pharyngitis and sometimes complications. The group A beta hemolytic streptococci has incubation periods of either from 12 hours. Presenting symptoms with as usual fever and throat dysphagia, exudate over the tonsils, enlarged neck nodes, rhinorrhea. Cough are not common. Uncommon in infants due to the presence of maternal IgG and also the lack of pharyngeal receptors for these bacterial agents. There is two rapid tests as enzyme immunoassay rapid antigen test the optical immunoassay rapid antigen test. Sometimes we do culture if there is a rapid antigen is negative to identify for thinking about the risk of rheumatic fever. Also, the antistreptolysin antibody test is less used now. We depend sometimes on the central criteria, which is the modified central criteria: presence of fever, absence of cough, and the presence of pharyngeal exudates and enlarged. Patients with negative throat cultures has little efficacy or no efficacy for using antibiotics. Penicillin also, if the patient is allergic to penicillin, we use erythromycin, which has a macrolide, and also cephalosporins. This is the treatment of choice in cases of bacterial infection, and you must be aware of the beta-lactamase producing organisms. Those will be resistant to penicillin. Complications, suppurative complications as otitis media and sinusitis, non-suppurative as glomerulonephritis, rheumatic fever, proceeding to rheumatic heart disease, Grisel syndrome with subluxation of the atlantoaxial joint due to infections in the nasopharynx mainly, inflammatory process presence with torticollis. Torticollis means like tilting of the neck due to spasm in the sternocleidomastoid. This might happen with a patient with a history of head and neck infection or after head and neck procedure, surgery in the nasopharynx with causing severe irritation. For reaching the diagnosis for rheumatic fever, we should fulfill following this Jones criteria with the modified Jones criteria, and fulfilling two major criteria and one major with two minor criteria, and the patient must have evidence of a preceding infection of group A beta hemolytic streptococci. This patient with acute rheumatic fever have high risk of recurrent attacks, so we do antibiotic prophylaxis as we use long-acting penicillins, and this does not stop the risk of developing acute glomerulonephritis. The scarlet fever has a post streptococcal sequelae with a streptococcal infection is the erythrotoxin. Patient present with tonsillitis, circumoral pallor, strawberry tongue, which is swollen, red, mottled, petechiae and spots over the hard and soft palate, skin rash, sparing the face, palms and soles, covering mainly starts on the chest and trunk, and might proceed to discrimination. Also, to confirm the diagnosis, we do a swab and do a culture and sensitivity for it. And also, there is a test called the big test. The treatment is the same. Viral infection, the herpes virus type 1, which is the usual. The type 2 is mostly genital. Primary herpes symptoms infection is mostly a gingival stomatitis, mostly involving the lips and the gingiva. Rarely causes acute pharyngitis, commonly in children with 10 months to 3 years age, malaise, fever, and pharyngitis, vesicular lesions that bleeds and is covered with black crust, and ulcers covered with gray exudate over the tonsils. Acute illness, it evolves over 7 to 10 days. It has a very rapid regression with symptoms and the lesion improves. Rarely it might be dissemination to the central nervous system, causing encephalitis. It's with a very high mortality. the virus can remain latent and might be reactivated under a variety of stimuli. Sometimes it becomes dormant in sensory and neural ganglia. When there is reactivation, it might recur. Treatment is symptomatic. The use of antiviral as a cyclovir. Mostly we recommend it for the immunocompromised, for the fear of central nervous system spread and spread of the infection, and it might be this measles. There is conjunctivitis and these complex spots with these lesions over the buccal mucosa, lymph nodes, lymphoid hyperplasia. Treatment is mostly symptomatic. It's self-limiting problem. The mortality from the bacterial soup, the Epstein-Barr virus infecting the B cells. The main concern here is it have a link with developing some malignancies as nasopharyngeal undifferentiated carcinoma and the Burkitt lymphoma. It has a direct association with it, the splenomegaly, hepatomegaly, and also diagnosing by the complete blood count with showing atypical lymphocytes, the hepatomegaly with the hepatitis, and also the monospot test, which might be negative in children less than 10 years, and also identifying antibodies of the viral capsid might be helping for diagnosis. Also, depending on the IgG, which for older infections, and the IgM of a short-term recent infection. Those antigens, they present for some time and they help in diagnosis, and they might be positive for life. The cytomegalovirus, it's a member of the herpes viridae family. It has congenital and acquired infections. It might be asymptomatic, but the main concern is it causes the infectious mononucleosis. It's a syndrome mostly caused by cytomegalovirus, also toxoplasma, rubella, hepatitis A, and HIV and adenovirus. The clinical picture, it has a febrile type, unknown fever, not responding to treatment, and generalized lymphadenopathy with the adenose type, and there is multiple throat ulcers, and also sometimes present with jaundice due to the infectious mononucleosis. Epstein-Barr virus might be the cause. CBC shows atypical monocytosis, the monospot test, pulmonary test, and a rash that appears with the use of ampicillin. Also, spleen enlargement, hepatitis, and rash. Infectious mononucleosis, this shows this membrane covering the tonsils. It can be diagnosed by positive pulmonary test. It's better to avoid using antibiotics as it has a severe urticaria effect, and also the appearance of rash. The HIV type 1 has signs mimicking the Epstein-Barr and might present with fever, malaise, myalgia, photophobia, lymphadenopathy, and micropapular rash. So it might be considered. Other factors might be helping in the diagnosis. Other systemic diseases, leukemia and granulocytosis, were leukocytes less than 2,000, mostly post-irradiation and post-chemotherapy. The sore throat and the dysphagia and ulcers in the oral cavity, the pharynx, enlarged lymph nodes, and sometimes secondary bacterial infection, which could be fatal. The treatment is mostly by isolation, antibiotic, receiving fresh blood transfusion, and treating the cause, which is by removing stopping the chemotherapy and stopping the diphtheria, the Corynebacterium diphtheria. It's a gram-positive aerobic. It's a toxigenic bacteria. Involves the oropharynx, nasal, laryngeal, and also genital. Low-grade fever with severe toxemia, with severe lymph node enlargement. The developing of the membrane is a characteristic unilateral grayish-white, exceed the limits of the tonsils, and also it's firmly adherent, which leads on removal. The vaccine, the DPT, decreased the incidence of this bacterial infection. Complications, it's due to different causes. The laryngeal obstruction could be due to the membrane that might be detached, might be occluding the airway. Also the vagal neuritis as a post-diphtheric complication, post-diphtheric paralysis. Also the bronchopneumonia due to the spread of the infection. Also might help to might lead to lung collapse and respiratory failure. Cardiac toxic myocarditis, vagal neuritis, which is late and leading to heart failure. Liver cell failure, toxic nephritis, neurological. This is the post-diphtheric paralysis. There's the palatal paralysis with the nasal regurgitation of fluids and food, and the nasal tone, and ocular muscles due to affection of the cranial nerve, third, fourth, sixth cranial nerve, leading to external and internal ophthalmoplegia, leading to diplopia and blurring of vision. Pharynx and larynx with dyspnea and stridor, and dysphagia, and intercostal muscles and diaphragm, which add to the respiratory difficulties. There is differential diagnosis of membranes on the tonsils: the acute focal tonsillitis, diphtheria, which with its characteristic membrane, scarlet fever, Vincent's angina, and systemic disease like leukemia, granulocytosis, infectious mononucleosis, and fungal, and the malignant ulcers in case of malignant oropharyngeal malignancies. Sometimes there is secondary infection over it, so this might be put into defensive angina. It's an anaerobic organism due to Borrelia vincenti, with severe local pain with absence of general toxemia. Whether the pain is out of proportion to what we see on examination, this killing pain has severe referred earache and tender lymph nodes with bad breath. There is a membrane or ulcer covering the tonsils, palate, or gums, treated as acute tonsillitis, and mostly it's a universal. The ulcers of the pharynx and oral cavity, locally trauma due to a sharp or bad tooth, sometimes chemical agents, infective, and malignant tumors might present as malignant ulcers, and general causes due to gastroesophageal reflux disease and dyspepsia and malabsorption. This is a diagram for a malignant ulcer. That might be a presentation of the oropharyngeal and oral cavity malignancy. The abscess ulcer is the commonest. Small group of painful ulcers or one big ulcer. It might resemble a malignant ulcer. due to malabsorption and reflux, and sometimes treated by adding folic acid and different vitamins. There is no universal treatment for it. It's self-resolving, avoiding only secondary bacterial infection. The aphthous ulcers, different diagrams. The whooping cough with a Bordetella pertussis. Also, it's due to the DPT. It's less common now. It has a paroxysm of coughing by inspiratory stridor-like sound. It's called the whooping cough. Whooping cough is in Arabic as su'al ad-diki, with a croupy sound. It has 3 stages: the catarrhal stage, and the paroxysmal stage, and convalescent stage. It lasts about. It starts with the catarrhal stage, lasts about 1 to 2 weeks. Low-grade fever, upper respiratory symptoms, mild symptoms, and the paroxysmal stage with the characteristic coughing and the exudates. Fever less, takes a longer time, and the convalescent stage. It's a prolongation of this self-limited disease. Antibiotics will not be of a big help. Immunization by the DPT make this condition. Gonorrhea, due to Neisseria gonorrhea, mostly asymptomatic. It has a specific culture with a chocolate agar media. Treatment is penicillin, tetracycline, cephalosporin, and quinolones. Also, rare condition, it's a chronic granulomatous, as the rhinoscleroma, with different stages where there is catarrhal and hypertrophic and fibrotic stages. Less common in the pharyngeal region, more in the nasal, as it's called rhinoscleroma, and also sometimes maybe a cause of laryngeal stenosis, and sometimes laryngeal. For the syphilis, the organism is a Treponema pallidum. It has different stages, starting with the congenital, primary, secondary, and tertiary. The primary, it has a painless solitary chancre at the site of inoculation, and it's a sexually transmitted disease. The inflammatory infiltrates has characteristic histologic hallmark, which is the end arthritis obliterans. The secondary stage with the pharyngeal tonsillitis and the skin lesions and lymphadenopathy, and this mucosal patches with on the pharynx, with a silver gray appearance with her red margins. It's painless and superficial erosions. 1/3 will go into spontaneous remission, 1/3 will proceed with a latent disease, and another 1/3 will progress to tertiary gamma syphilis, which mostly involves the CNS and the aorta. Sanguinolimited lesion leads to central coagulative necrosis. It has a characteristic finding on microbiology and pathology. Testing will be either non-specific or specific. The VDRL test, Venereal Disease Research Lab, and rapid plasma antigen test used as a screening test. Confirmatory will use the specific treponemal antibody test. Treatment will be penicillin, and for allergic patients, tetracycline. Fungal infections, mostly immunocompromised, for those with chronic disease like diabetes. candidal infections, which is the Candida albicans, is the most common, which is normally present in the oral cavity, but infections need an immunocompromised condition for the infection to take place. HIV post-irradiation patients and diabetics uncontrolled. It needs a special stain with the periodic acid Schiff stain and smears for culture on severed agar. Topical nystatin and oral ketoconazoles and fluconazole, and also amphotericin B might be used, but this is in severe conditions. We will need a systemic medication. Mostly local treatment will be effective with correction of the general condition. Deep mycosis like Cryptococcus rhinosporidiosis, histoplasma, Candida albicans, you must search for the cause. These mostly occur in immunocompromised patients. The prolonged use of antibiotics might be a common cause for it. Also malnutrition, hypovitaminosis, diabetes mellitus, uncontrolled, and post-irradiation and HIV might be another causes. This is a picture for a case of disseminated candidiasis due to presence of HIV. This oral candida can be treated with mostly topical and systemic antifungal agents. Topical as nystatins and also ketoconazole could be topical and systemic. And there is dysphagia. Might also consider a presence of esophageal candidiasis. Actinomycosis. Actinomycosis bovis or Israeli, they present in the normal flora. They might be on the tonsils and also present with dental infections. It's a gram-positive anaerobic bacillus. Sometimes may cause a deep neck infection with a small abscesses that might be rupturing, causing small fistulas that has forms into tracts for this fistula, and it might have sulfur granules. Treated with penicillin, but for a long time, and it has a tendency to recur if inadequate treatment. Also, granulomatous diseases causing pharyngitis, TB, leprosy. Will not be into much details considering this granulomatous disease, but the pharyngeal tonsillitis and involving the pulmonary involvement might be important landmark for TB. Also in leprosy, the nasal cavity, either it's lepromatous or tuberculoid. Sometimes there is a reaction as it's mimicking the tuberculous reaction, and especially in tuberculoid leprosy, and sometimes there is nerve damage with it. The treatment will be rifampicin and dapsone, and it needs to be discussed in detail in other sections. Radiation pharyngitis, it's oral pharyngeal mucosa, atrophic changes due to inhibition of cell division and high cellular turnover. Treatment is to you can use topical steroids in proper hydration for due to xerostomia that happens due to atrophy of the glands secreting the saliva, and dryness in the throat, sucralfate, diphenhydramine, and local antibacterials might be helping. This Stevens-Johnson syndrome, with an oxidative erythema multiforme. Also, it's usually following an upper respiratory tract infection and usage of certain medications like anticonvulsants and barbiturates. There's a lesions which is a vesicular and bulbous lesion, painful, involving the mucosa and the skin. It might ulcerate and bleeds, and also there is fever and pulmonary involvement, mostly self-limiting. The skin and the mucosal lesion need a few weeks to resolve with a very high recurrence rate. Treatment as symptomatic, with receiving enough fluids and electrolyte correction, and treating the secondary infection that might be topping this condition, and also stopping the offending agent, the medication, and treating the upper respiratory infection. Idiopathic pharyngitis is a pharyngeal pain without an obvious source. Postnasal discharge might be caused, reflux, sometimes subclinical infections, dietary, like excessive intake of acidic food, hot, spicy, and habits like smoking, some medications like mouth gargle, throat sprays, sometimes receiving irritants, and some drugs with local irritant effects. Reaching a diagnosis, we'll start by the history, asking in patients onward, looking for symptoms of common cold, change of voice, systemic symptoms with liver and spleen enlargement, and examination by checking the throat, examining the oral cavity and the oropharynx, checking the cervical lymph nodes, and the use of the flexible fiber optic, checking starting from the nasal cavity to the nasopharynx to the oropharynx and hypopharynx and larynx. Investigations for the bacteria, we consider throat swab for culture and sensitivity. Also blood, checking the blood samples like complete blood count, specific tests like monospots for Bonner test for infectious mononucleosis, and the dig test for the scarlet fever, and the Charlton test, and sometimes sternal puncture for the throat swab should be taken when diagnosis. A throat swab is suspected from the clinical and epidemiological finding, and the patient is not already taking any antibiotics. Antibiotics cause no growth over the throat swab and might be a diagnostic difficulty by the patient receiving an empiric antibiotic treatment. This might be causing a failure of getting a proper result from this throat swab. Culture is usually the only test required. However, antibiotic sensitivity should also be requested in penicillin allergic patients due to the emergence of erythromycin-resistant strains of Streptococcus. Treatment: viral throat, we need gargling symptomatic treatment. For bacterial strep infection, the antibiotic of choice is penicillin V, and also some alternatives, the amoxicillin and erythromycin for allergic patients allergic to penicillin. 10 days mostly the duration of the treatment. Other causes like mononulases and leukemia granulocytosis, as discussed earlier.